Big thanks to the organizers of this event for inviting me to speak about U equals to U. And the title of my topic today would be the intersection of stigma and U equals to U. And I'll be speaking today from the clinician's perspective. So the outline of my talk today is I will be talking about the science behind U equals to U, the hesitancy of clinicians to discuss U equals U, the medical and psychosocial implications of U equals to U, and how we can move forward with dealing with some of these issues and recommended strategies for encouraging clinician-initiated discussions of U equals U. So U equals to U, simply defined, is the overwhelming scientific evidence that states that when people living with HIV who take antiretroviral therapy as prescribed and who achieve and maintain an undetectable viral load cannot sexually transmit their virus to an HIV negative partner. And this is on the right, you can see the Association of HIV Medicine Guidance for Healthcare Professionals. On the left, you can see an AIDS map resource, which states a similar sentence. The scientific evidence is clear. Someone whose HIV is undetectable does not pose an infection risk to their sexual partners. And so U equals to U largely applies to sexual transmission of HIV. Research has not categorically established zero risk of transmission when it comes to occupational exposure, but by extrapolation, we know that there is negligible risk in the setting of an undetectable viral load. The evidence behind undetectable equals to untransmissible has been around for nearly 2 decades, and it goes back to the initial studies conducted in Rakai. Since 2011, we've had 4 pivotal studies, mainly in the form of HPTN 052 and 3 other observational studies, partner 1, partner 2, and the opposites attract. Now, the HPTN 052 was one of the first randomized controlled trials to show that early initiation of antiretroviral therapy was associated with significant reduction in HIV transmission. What we see in the HPTN 052, with early initiation of antiretroviral therapy, there was 0 linked HIV transmissions when the HIV positive partner was virally suppressed. When we look further into the 3 other observational studies, the partner 1, partner 2, and opposites attract, we look at significant numbers of participants providing, in the partner 1, 55,193 condomless sexual acts, partner 2, 76,991 sexual acts, and opposites attract 12,500 condomless sexual acts. This amounts to about 125,376 condomless sexual acts when the HIV positive partner has an undetectable viral load, and despite all that, we find 0 linked HIV transmissions amongst these serodiscordant relationships. And this has been similar whether we applied it to homosexual or gay man or heterosexual couples. Partner 2 and opposites attract recruited more MSM partners as the confidence earlier on to extrapolate this to MSM was lower. And so now we have increased confidence that this applies to both heterosexual and MSM couples. U equals to U also applies even when STIs were detected, because these studies detected very high rates of STIs up to 1 in 3 of couples. Looking at awareness studies and health outcome studies of people living in HIV when U equals U is discussed by their healthcare provider. On this slide, we have the Positive Perspective Study, which is one of the largest global HIV patient-reported outcome study to date involving more than 2,000 people living with HIV across 25 different countries. This was conducted between 2019 and 2015, and they looked at several outcomes, including discussions of undetectable equals to untransmissible with a healthcare provider. This was published in STI. So what we can see essentially from this chart is that these are just findings of the Positive Perspective 2 study, which showed that 1/3 of people living with HIV were not told about U equals to U by their healthcare providers. And what we see is on the chart is a range of health-related outcomes according to 3 different groups. So the red bar denotes those people living with HIV who were completely unaware of U equals to U. The blue chart denotes people living with HIV who were aware of U equals to U from a non-healthcare professional source. And the black bar indicates those who were informed of U equals to U by their healthcare providers. And what you can see essentially is that as you move across to the right, the black bar generally outperforms the blue and red bar on most occasions across a range of health-related outcomes, be it viral suppression, mental health, optimal physical health, and sexual health. So what it says essentially is that those patients living with HIV who have had those discussions with their healthcare provider of U equals to U is associated with higher rates of viral suppression and positive health outcomes. So why should providers discuss U equals to U with people living with HIV? Now, this is the positive medical and psychosocial implications and benefits are well known now. Firstly, it motivates and encourages initiation and adherence to antiretroviral treatment. It removes the fear, the shame, and the guilt around potential HIV transmission, enabling sex without fear. It reduces HIV-related stigma at all levels, community level, healthcare provider, clinician level, and personal level in the form of self-stigma. We know it improves mental and emotional well-being of people living with HIV. And on a community level, it reduces barriers to testing, encouraging people to come forward to get tested, and has changed discussions around conception and wanting to conceive. It allows HIV serodiscordant couples to conceive naturally. We no longer have to refer patients for sperm washing or more sophisticated assisted reproduction techniques. And importantly, at a policy level, it has affected criminalization laws around decriminalization of people living with HIV who have transmitted HIV to partners unknowingly. So why are there concerns among providers to talk openly about U equals to U? This is largely to inherent paternalistic and prejudiced attitudes. We know with U equals to U, it is about being non-infectious, and condoms are not required to prevent sexual transmission of HIV. Yet, healthcare providers have initially and continue to be concerned around sexual risk compensation. So this is essentially when one HIV prevention strategy is adopted, it affects another HIV-related prevention strategy. So the concern here is that by adopting and applying U equals to U, people living with HIV will engage in more condomless sex and have more sexual partners. And this is largely perceived as being sexually irresponsible, with possible increase in other sexually transmitted infections, and may be an incentive for healthcare providers to withhold U equals to U information. This is not the first time we've been here. We've been here before with oral contraceptive pill. We've been here with at the beginning of antiretroviral therapy. We've been here with post-exposure prophylaxis. And similarly, we're going through sexual recompensation and concerns with various stakeholders with PrEP now. A lot of these concerns, particularly around risk compensation, are rooted in prejudice and stigmatizing and paternalistic attitudes towards key populations or sexual minority norms, and a need by doctors, policymakers to dictate how people living with HIV should have sex. So essentially, a lot of U equals U stigma is around sexual stigma. Despite robust evidence behind U equals U, there still continues to be widespread lack of knowledge, misinformation, and disbelief of the science behind U equals U amongst healthcare professionals. Concerns that patients are unable to maintain good adherence to antiretroviral therapy, particularly in resource-limited settings, where less frequent viral load monitoring is likely to occur, and concerns because U equals U is dependent on maintaining a sustained undetectable viral load. In the event of HIV transmissions occurring as a result of discussing U equals U, healthcare providers fear being blamed for these transmissions. But most of all, there is general discomfort, particularly amongst infectious disease physicians or primary care physicians in Asia about discussing sex and sexual behaviors with patients. And yet, as clinicians, particularly as HIV providers, we really should be the ideal advocates for U equals to U. And these are largely because we're in a privileged position as respected professionals and experts. We have this very unique long-term relationship with patients. We're able to influence policy on various scales and magnitudes, and we also participate in the HIV sphere in various capacities, either as key opinion leaders, prescribers, and we all, we all aspire to practice evidence-based medicine. Evidence-based medicine is central to the practice of all clinicians. In the context of U equals to U, having sex with a person living with HIV who has maintained an undetectable viral load constitutes safe sex, irrespective of whether condoms are used. And this is important to understand. Sometimes very hard to convince policymakers and other healthcare providers. Saying that this is unsafe or risky sex is not only inaccurate, it is stigmatizing and counterproductive to what we're trying to inform patients. So what can we do as clinicians do about this? Well, we can try and communicate this as effectively as possible. And the language that we use matters very much. And this is going back to the British HIV Association position statement that was released in November 2018 and the recommendations around communication. They recommend that it's important to use clear, consistent, and unambiguous terminology when discussing U equals to U. So use terms such as zero or no risk of sexual transmission, and be confident when saying this. Avoid terms such as negligible risk, virtually impossible, or extremely low risk, which tends to confuse people. It's important to discuss U equals to U proactively, so we should initiate those conversations with all people living with HIV rather than waiting for them to bring up these discussions at appropriate points during care. So whether it's at testing, whether it's initiation of antiretroviral therapy, whether it's to improve adherence, or whether it is at the point where they're considering planning a family. It's important to it's important to share and explain the scientific evidence behind U equals to U, emphasizing the medical and psychosocial benefits of U equals to U. The challenge, of course, the world that we live in is that clinicians find it very difficult to cope with zero risk. So hence the paradox. There is never a never, and there's never an always in medicine. So even if you communicate that there's a zero risk, there's always going to be that odd clinician who say, well, there's never anything that you can say never in medicine. In terms of education and training, this is also a strategy where we can help to disseminate U equals U. So important to include U equals U content in medical education at all levels, be it undergraduate and postgraduate, medical and nursing school curricula. So important to include nursing in this. They're very much part of the solution. Continuing medical educations, department, unit induction training programs. U equals U effectively elevates discussions around sex, strengthens the importance of sexual health. U equals to U can be the focal point for improving and teaching communication skills, public health, gender and sexual studies. It's important to explain that risk compensation is not a medically justifiable reason to withhold information and is in fact against medical ethics. Through U equals to U, and although it applies to sexual transmission largely, has the potential to influence other areas of healthcare. For example, it has the potential to change local occupational health guidelines in favor of HIV-positive healthcare workers continuing to work in healthcare. It has the effect also on affecting and changing occupational and non-occupational post-exposure prophylaxis guidelines, largely in recommending that PEP is not required in the setting where the source patient of a needle stick injury has an undetectable viral load. In the Asian setting where levels of stigma in healthcare settings are particularly high, it also has helped change outdated infection control protocols pertaining to HIV-positive patients. For example, being placed last on the surgical list of cases for operations. And this is something that happened more recently in World AIDS Day discussion last year, where during World AIDS Day we discussed, the topic was, should healthcare workers be allowed to work? And we had all the right people at the meeting. We had the head of surgery, we had infectious disease consultant represented by myself, we had the head of occupational health and the head of nursing. And this was on our opportunity not only to update them about the latest Malaysian Medical Council guidelines on bloodborne viral infections and healthcare and HIV-positive healthcare workers, but it was really to inform them on what they knew beforehand. And unsurprisingly, our colleagues who work outside the infectious disease field are very unaware of U equals U. And this is despite having had U equals to U as our central theme in the previous 2 World AIDS Day meetings. Through discussion, through engagement, we found it easy to work with the head of surgery and the head of occupational health, and managed to convince them that U equals to U played a significant part in why healthcare workers should continue to be allowed to work within healthcare if they were monitored regularly and continue to be virally suppressed. And this is moving towards changing of local guidelines within the hospital. Important to also use tools, evidence-based tools, to facilitate patient-provider conversations on U equals to U. For example, electronic medical records can have prompts and embed U equals to U in EMRs to raise prompts about whether U equals to U discussions have been had. And important to have visible information either in the form of pamphlets and patient-targeted education materials in clinics, and also translated to other languages. As part of the strategy to disseminate U equals to U information, it's important to have these guidelines, to have U equals to U included in guidelines, either country guidelines as well as global or regional guidelines for HIV care and treatment, such as in WHO, where they've used wording such as it's important to raise awareness and promote the knowledge about U equals to U within the healthcare sector, communities, people living with HIV, and other partners in the HIV response. Similarly, since 2019, the American DHH guidelines also have similar wording, applying U equals to U in their guidelines, and stating that maintaining a plasma viral load of less than 200 copies per mil prevents sexual transmission of HIV to their partners. Endorsement of U equals to U by medical societies and professional organizations at the highest level. Here it's with UNAIDS, International AIDS Society, and the Australian Society of HIV Medicine, affirms that discussing and informing U equals to U by healthcare professionals with their patients is the expected standard of care, and it's a professional responsibility of all healthcare providers. And withholding or not having these discussions is providing substandard care. And this goes back to 2018, where the British HIV Association encouraged universal promotion of undetectable equals untransmittable, and played a significant part in raising awareness and initiate around discussions by healthcare providers with their patients. In the Malaysian context where I'm from, a lot of work needs to be done. A lot of people, of course, a lot of healthcare providers have been deployed to work in COVID-related health areas. And certainly this area hasn't seen very much progress, certainly over the past 2 years. What we need, though, in the Malaysian context is greater community advocacy and drive by the community. It needs to be formally endorsed by professional HIV organizations and societies within the country. We need more health provider champions, not only national campaigns, but city campaigns. Now, a lot of U equals to U is very much messaging is limited to social media. But more importantly, we need to reframe HIV with a focus on health and longevity resulting from viral suppression. And we as a society, particularly in the Asian setting, need to feel more comfortable talking about sex. Now, of course, as a healthcare provider, as an advocate, and as a clinician, and working in an academic teaching hospital, we're involved in research. And this is some of the work that we're currently doing with our US collaborator, Valerie Earnshaw. Although not directly applicable to U equals to U, it involves moving away from assessment of stigma of key populations in healthcare settings and moving towards implementing stigma reduction tools via a popular teletraining platform, so Project ECHO, to reduce clinician stigma. And then looking at implementation outcomes in the form of reduction in clinician stigma, HIV testing, and prevention and linkage to care. This is largely being done initially through implementation of photo voices, representing the voices of the community, and it's collected largely around experience of clinician stigma amongst 30 to 35 key stakeholders. This is then used to test pilot Project ECHO in 3 different arms. One arm which involves Project ECHO and this applied stigma reduction tool, looking at short-term implementation outcomes such as acceptability, feasibility, and preliminary impact of the intervention. So in conclusion, U equals to U really is a game changer. It may help address stigma, but it's not a magic wand. It forces our narrative to evolve. People will only hear if we tell them repeatedly, persistently, and loudly. Thank you.